Good evening, everybody, and welcome to our introduction to the National Lung Cancer Screening Program, Webinar 1. Thank you for joining us this evening. And first, I would like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters, and culture. We pay our respect to elders past, present, and emerging. And I join you tonight from the Darawal country in South Sydney. We also acknowledge Maori as Tangat as a binational college. We acknowledge Maori as Tanga Whatanaru and the Treaty of Waitangi Partners in Aotearoa, New Zealand. Together, we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education. Thank you for attending our first webinar in the series of the Introduction to the National Lung Cancer Screening Program. We're very excited by this, and we have for you tonight three presenters. The first is Professor Dorothy Keefe, the CEO of Cancer Australia, Australia's National Cancer Agency. And prior to this, she was a medical oncologist at the Royal Adelaide Hospital and Professor of Cancer Medicine at the University of Adelaide. Her long-term research interest has been supportive care in cancer, with a particular focus on gastrointestinal toxicity of cancer therapy. Dorothy has a keen and strong interest in health reform, career development, and mentoring, and she's committed to patient-centered care, reducing unnecessary variation in cancer outcomes. We also have Dr. Miranda Simonovic, who is a thoracic radiologist at Northern Imaging Victoria, Northern Health in Melbourne. Miranda is the chair of the Australian New Zealand Society of Thoracic Radiology and is our clinical lead for the National Lung Cancer Screening Program on behalf of the Royal Australian New Zealand College of Radiologists. Miranda sits on the National Lung Cancer Screening Program Expert Advisory Committee and the Data Development Working Group for the Department of Health and Aged Care, and is a member of the Lung Cancer Working Party of the Thoracic Society of Australia and New Zealand. At Northern Health, she is the CT Clinical Lead and Director of Training. And we're also joined this evening by Professor Catherine Jones, who is a subspecialist in cardiothoracic radiologist and based in Brisbane. She's the Director of Cardiothoracic Imaging at DetectedX, as well as holding the academic title of Adjunct Professor at the University of Sydney. Catherine is the cardiothoracic lead at radiologist at IMED Radiology, one of the world's largest networks. She's also the clinical chess lead for AI development at Analyse AI and sits on multiple governance committees and is also a member of the board of directors at the Australian New Zealand College of Radiologists. So now I'm going to hand over to Professor Dorothy Keefe. Dorothy would have liked to have been with us this evening. Unfortunately, she is unable to, but she has forwarded us a short video presentation.
Hello, my name is Dorothy Keefe, and I'm delighted to be presenting to you today from the lands of the Gadigal people of the Eora Nation on the upcoming National Lung Cancer Screening Program. This program is an exciting opportunity to improve lung cancer outcomes in Australia and is the first new cancer screening program in Australia in over 20 years. The program was announced in the 2023-2024 budget, and the government committed over $250 million to establishing it. The screening program will begin for eligible people on the 1st of July 2025. It will largely consist of biennial screening for people between the ages of 50 and 70 who are current smokers or who stopped within the last 10 years and who have a 30-pack year history of smoking. The other important thing is that people must not be symptomatic. If people are symptomatic, they don't go into the lung cancer screening program, they go straight for investigation of their symptoms. In order to set up the program, we have established two new bulk billed MBS items for low-dose CT scans. These are bulk billed, and so patients will not be out of pocket at the point of screening. We will use the existing low-dose CT scan infrastructure in Australia in both public and private settings, but in acknowledgement of the fact that there is not quite enough of this around the entire country, we will also be introducing mobile screening to deliver services in rural and remote communities. As you know, there is more lung cancer in rural and remote communities, and it's important that everyone is enabled to access the program who needs to access the program. And we will also have structured reporting of the CT scans so that we will most efficiently be able to register how much at risk people are of lung cancer. And these structured reports will be fed into the National Cancer Screening Register, which will be expanded to include lung cancer. As you can imagine, with low-dose CT scanning being the investigation of choice for the lung cancer screening program, this is really a major radiology activity and is being done in collaboration with the radiology sector. We have been working with the radiology sector and with RANSCA over the past few months and years in order to ensure that everything is ready for the lung cancer screening program to start on the 1st of July. RANSCA has been developing with us and with the Department of Health the nodule management protocols for the screening program, the structured reporting templates, the low-dose CT scan imaging acquisition protocols, and the additional findings guidelines, because of course there will be findings made on some of these CT scans that are important but are not lung cancer. And it's vital that we investigate and treat these properly where needed. The nodule management protocol feeds into the National Cancer Screening Registry data fields. The structured reporting template and the low-dose CT imaging acquisition protocols fit into the program guidelines, and the additional findings guidelines will help us with the radiology education materials and modules that need to be finalised, are almost finalised now, in order for the professions to be ready to undertake the program. This is a more complicated slide, which is of the screening and assessment pathway, but I want to reassure you that actually it flows quite easily through. Up on the top left-hand corner, you can see that where the patient is eligible, they will be referred on to a low-dose CT scan, and if they're ineligible, including being symptomatic, they'll be referred to appropriate clinical management. So again, the patients between the ages of 50 to 70, asymptomatic, history of cigarette smoking of at least 30-pack years, and if they're a former smoker, they've quit in the last 10. Have their eligibility checked by their general practitioner or appropriate health practitioner and referred on to a low-dose CT scan with their consent, obviously. Now, depending on what is found on the CT scan, there will be a different frequency of repeat CT scans. The standard one is that you have a repeat CT scan in 2 years' time if there's a no or very low risk of lung cancer. However, if you're in a low risk category, you will have a scan again in 12 months. If you're a low to moderate risk, you'll have a scan in 6 months. And if you're a moderate risk category, you'd have a repeat scan in 3 months. If the scan shows that there is a high risk of lung cancer, that person will then be referred outside of the program to a respiratory physician linked to a lung cancer MDT. The patient will then be investigated and follow up as appropriate for their scan and other investigation findings. If no cancer is found, they will be returned to the standard program, and if cancer is confirmed, they will obviously be treated for that cancer in line with treatment guidelines. The category that many people worry about is this additional finding category, and there are guidelines in preparation for the management of these patients, and it will be as appropriate to the specific finding, and then they will continue in the program. If you require any more information on the program, please have a look at health.gov.au/NLCSP or lungcancerscreening@health.gov.au. Thank you, and I look forward to working with you all to improve outcomes for people affected by lung cancer.
My name is Miranda Sheminovich, and I will be talking about the role of the radiologist in the National Lung Cancer Screening Program. So where we stand today is a journey of more than 5 years in the making. beginning in 2019 with the then Minister of Health, the Honourable Greg Hunt, requesting Cancer Australia to conduct an inquiry into the prospects of the National Lung Cancer Screening Program. This was followed in 2020 with Cancer Australia releasing their report on the lung cancer screening inquiry, and in 2022 with the Medical Services Advisory Committee providing advice to the government on the National Lung Cancer Screening Program. In May 2023, the Minister of Health, Mark Butler, announced a national lung cancer screening program informed by advice from MSAC and also feasibility work that had been developed in the interim. And in 2024, Cancer Australia contracted RANSCAR to deliver the standardised reporting template, guidance for radiologists in reporting lung cancer screening CT, and supporting training resources. The Australian and New Zealand Society of Thoracic Radiology is a special interest group of the college and is responsible for clinical input towards RANSCAR's contractual obligations and radiological advice around the National Lung Cancer Screening Program design. The ANSTO-RANSCAR Lung Cancer Screening Working Group was established in the first quarter of 2024 and has undertaken a huge volume of work that has gone into developing the materials behind the NLCSP. Listed on the right are the 6 members of the steering committee, which sits under layers of RANSCAR governance and administers a working group that is 62 radiologists strong. This is a working group that is the largest such group ever supported by the college and works across 6 different streams of work, ranging from between 3 and 17 members, to develop all of the background that is going to support the workforce in this transition. We have across these different streams activity around quality assurance, around acquisition guidelines for low-dose CT and performing the studies that will serve the lung cancer screening program, the standardised reporting template, which will be submitted to the National Cancer Screening Register, which is being built out by 50% capacity, again, already housing the colorectal cancer screening program and the cervical cancer screening program, and will now house the lung cancer screening program. The Additional Findings Subcommittee has developed a framework around a standardised approach that is responsive to the Australian context for managing additional non-nodule findings on low-dose CT for lung cancer screening. And this has been an interrelated work, taking on feedback and advice from stakeholders, including the College of General Practice, the College of Physicians, our colleagues, the respiratory physicians and the Thoracic Society of Australia and New Zealand, the Cardiac Society of Australia and New Zealand, and subspecialty radiology groups, just to name a few. Training materials and delivery are in progress. This webinar forms the first of a series of webinars that will cover off topics around the lung cancer screening program and radiology interpretation and practice. And we'll hear more about that from Professor Jones tonight. There is also work around the use and implementation of nodule detection and volumetry software to support radiologists in delivering lung cancer screening. The ANSTO-RANSCAR Lung Cancer Screening Working Group central piece of work has been the NLCSP Nodule Management Protocol. This realises the directives from the Medical Services Advisory Committee of using the PanCan Nodule Malignancy Risk Calculator for interpretation of baseline scans and using a framework for follow-up imaging where there are prior images available for comparison of a modified lung RADS framework. This nodule management protocol has been months of evidence review, development and testing in the making. This has been with feedback and input from the Thoracic Society of Australia and New Zealand and is endorsed by the Department of Health and Aged Care. The PanCan Nodule Malignancy Risk Calculator is a mathematical model that uses demographic, clinical and nodule variables to arrive at a probability of a lung cancer diagnosis for that nodule within the next 2 to 4 years. This QR code takes you to an online platform for the PanCan calculator, and this is the major tool used at baseline imaging when there is no prior imaging available for comparison. It was derived from the Pan-Canadian Early Detection of Lung Cancer Study screening data, which is a major large-scale study, and the calculator has been validated in subsequent further large-scale studies. The calculator looks like this on the right-hand side, with a number of demographic and clinical variables that input to arrive at a cancer probability. We have age, sex, the family history of lung cancer, which is a piece of information that is mandatorily provided on the radiology referral for the lung cancer screening program. Emphysema, which is a radiological judgment of presence or absence. Factors around the nodule, including the size, the morphology, its location in the lung, the background lung appearance in terms of number of background nodules, and spiculation in the border of the nodule itself. And then that cancer probability is expressed as a percentage. And this is used in the interpretation of these baseline scans. The use of the PanCan calculator allows optimized selection of low and high risk category participants. So what we see in comparing an approach that utilizes the PanCan calculator at baseline imaging with a lung-RADS style approach that has an annual screening interval is that 75% of participants are able to be safely identified and sent to a 2-year follow-up instead of that 12-month interval. So the resource impact on delivering a program with this as its foundation is absolutely profound and allows the Australian program to be accelerated through in a tight resourcing environment where we wouldn't access that kind of backing financially and politically. So this is a safe and effective tool that is really facilitating delivery of this program. What it also allows is for a much smaller percentage of participants to be selected for referral for further workup. And we see that in comparing the PanCan approach again to this lung-RADS framework of annual CT, that 2.8 compared to 7.4% get selected for referral for further workup in a multidisciplinary team setting. And that's for the same number of cancers detected. So that's the rationale behind the advice to incorporate this calculator in our imaging and how the program will be delivered in our context. Lung-RADS, many people will have heard of, not many people will have used. It's a standardized reporting, management, and data collection system developed by the American College of Radiology, specifically for lung cancer screening with low-dose CT. Multiple historic iterations exist that have been based and improved upon using accumulating evidence and experience. It has been modified to accommodate the PanCan calculator and various interactions between baseline and follow-up imaging that occur in Australia's biennial 2-yearly program. In our program, a normal study goes on to a follow-up CT at 24 months and sifting out through the framework of lung-RADS to incorporate the elements of the framework that work with this, we've arrived at a bespoke nodule management protocol that is responsive to best available evidence and will be used for radiologists in their interpretation. So what is the role of the Australian radiologist in the National Lung Cancer Screening Program? Well, it's worth dwelling for a moment on the fact that only a minority of countries have a funded population-level lung cancer screening program. So we are entering an envied minority in the global lung cancer healthcare community with rolling out a program that is funded on a populational level. Australian radiologists have been central in the design and the journey to implementation of the National Lung Cancer Screening Program, and through the subcommittees and the Lung Cancer Screening Working Group, and with the administrative and logistical support of the college, we have developed a comprehensive suite of materials that will be available through RANSCAR to support radiologists, radiographers, and practice staff, from practice setup, integration with the National Cancer Screening Register, low-dose CT acquisition and interpretation, and support for standardised reporting. There will be a detailed radiologist education program for nodule management that Professor Jones will touch more on. So thank you very much for your attention. I will turn you over to Professor Jones for more on the lung cancer screening program.
Thank you, Miranda. Okay, so there's a lot happening in lung cancer screening in the design and implementation of this program. This is one of the biggest changes we are going to have to the healthcare landscape in Australia, and it's the first national cancer screening program for Australia in 20 years. So one of the key questions that underpins everything that we're going to do from here on in is, why are we actually screening for lung cancer? And in short, it's a very common cancer. It is the 5th most common cancer diagnosed in Australia, and it is particularly high prevalence in Aboriginal and Torres Strait Islander people. It is also the leading cause of death from cancer in Australia for both men and women. In fact, it's always within the top 5 causes of death from any cause in every census. So this is a very significant health problem for this country. And we understand as well that there are other vulnerable groups, including Australians that live in the regional and remote areas compared to those of us who live in the major cities. And so overall, there's over 8,500 deaths per year in Australia from lung cancer. And that's really what we're trying to address. Now, when we compare lung cancer to other types of cancer, we can see that it's only the 5th most common. So here we have a very appropriately teal colored, I think teal is the color we have chosen for the lung cancer program. A lung cancer is the 5th most common, but you can see it is absolutely leading the way. No one wants to win that race, but leading mortality. We can also see that there is an increase in mortality the further you get from a major city, and also with the lower the socioeconomic status, the higher the mortality from lung cancer. And so we have many years of data indicating that these trends are unfortunately not improving. Again, comparing to other types of cancer, we can see that the percentage, the actual overall number is pretty high. It's, 3rd, 4th, 5th, regularly across all of the census data in terms of how common it is diagnosed. Now, when we look more specifically at the Aboriginal and Torres Strait Islander patient population, we can see that both the incidence and the age are worse. So it is more common in the Indigenous community and it occurs at a younger age. And then the image on the right side of that screen shows that the mortality is in some of these age groups 2 or even 3 times as great for non-Indigenous persons. So, this is definitely something that has been a focus from the very beginning of the program. And I know that Dorothy, in her slides, was mentioning that this is a collaboration between the Department of Health and Aged Care, Cancer Australia, and NACCHO, so the National Aboriginal Community and Community Healthcare Centre organisation. So it's a really important piece to always consider the development, the design and the implementation of this program for our Indigenous community. Now, in addition to these dreadful statistics, we know that the number of lung cancer cases continues to rise year on year. It's predicted to be, about 17% increase by 2031. And the reason for this is multifactorial. It's predominantly because we have an aging population. But we also understand that there are changing rates of smoking and an increasing effect of some of our occupational and other risk factors. And so there's a lot of research that is underway to identify some of those other risk factors. But year on year, we have an increase in the number of patients who are diagnosed with lung cancer, and that is a global phenomenon. So now we've identified that there is a clinical problem, that people are increasingly getting lung cancer and that the treatment is, pretty poor. The outcomes are very poor compared to other cancers because of this high mortality rate. We have to look as to why. Now, if we see here the impact of early detection, and this is another key driver for implementing a national screening program. we know that compared to other types of cancer, whether it's breast, colorectal, melanoma, the vast majority of those cancers are detected in stage 1 or stage 2. Compare that to lung cancer, where we can see that, less than 12% of patients are diagnosed in stage 1 and 6% in stage 2. 40% of patients are diagnosed at stage 4, and there's 28% where we just haven't got the data. But that is definitely skewed compared to the other more common types of cancer that we see presented in this table. And that's for a number of reasons. Quite often the symptoms are non-specific, and by the time a patient presents symptomatically from lung cancer, it is more likely to have developed stage 3 or stage 4 disease. And so stage 4 disease, of course, as we would expect, is associated with poorer prognosis. Again, comparing this table on the right side of the slide, we know that all of the lung cancers have a very poor survival, but particularly those for stage 4. Now, this data is from approximately 2011, but we understand that compared to other cancers, the prognosis is still poor. You have a look at the difference between the prognosis of stage 1 lung cancer, which is a very high bar, compared to that of stage 4. And even with immunotherapy and other new treatments, that differential has certainly not been reduced. And so we understand that if we can shift the stage of diagnosis from stage 3 and 4 back towards stage 1, then we're able to more effectively cure patients through the treatment options that have available to them. So the next question is, okay, well, how do we identify patients who are at risk? How do we best screen? So we're screening with a low-dose CT scan. And this is, of course, backed up now by multiple studies that have been performed around the world. This is a meta-analysis of the lung cancer-related mortality for patients who've undergone low-dose CT screening programs. And this was a paper produced by a group here in Australia, and we can see that the risk ratio of death is significantly lower. And most of these studies were involving patients who were considered high risk because of their smoking status. And so really all the evidence that's out there to support screening for lung cancer with low-dose CT has focused on patients with a heavy smoking history. If we look at the two studies that have contributed the most to the literature, we have the National Lung Screening Trial from the US, which looked at two groups of high-risk patients who had a smoking history, and they screened with both chest X-ray and with low-dose CT. And you can see that the number of lung cancer cases was significantly higher in the CT screening group, and also that the deaths from lung cancer were significantly lower. It resulted in a 20% lower mortality rate in the CT screen group. So this was very big news back in 2011, and of course it led to many more studies and follow-up in the intervening time. So not to be outdone, a large European trial called the Nelson trial, based in the Netherlands and Belgium, also investigated using high-risk patients based on smoking status, and randomized patient to sort of no screening or to low-dose CT screening, at 0, 1, 3, and 5.5 years. And this showed a 24% reduction in mortality for male participants and 33% reduction in mortality for female participants. And they now have a greater than 10-year follow-up. And so this is pretty robust evidence that when using smoking status as a proxy for risk factors for lung cancer, low-dose CT screening causes a significant reduction in lung cancer-associated mortality. And so, as Miranda has already mentioned, the inquiry into lung cancer screening feasibility into this country in Australia has looked at all of the evidence and said, yes, we're going to proceed with a national program. So what does this look like for us? Well, the upcoming program has several goals, and obviously the first one is to try to reduce the mortality from lung cancer across Australia. The second one is to sort of focus on being able to offer smoking cessation advice to those eligible participants who are still smoking. And as I mentioned earlier, there is a persistent focus on those vulnerable patient groups, for example, those who are Aboriginal or Torres Strait Islander, or those that live in the regional and remote areas of Australia. To this end, there's MBS funding through Medicare to provide the low-dose CT for eligible patients who are referred to a radiology provider. The program will start on the 1st of July of this year. Now, this doesn't sound like it's very far away, and it's not. It's only a couple of months away, really. But we have been working on this through ANSTA, as well as the college, with all of the amazing support we've had from college staff, and all of the radiologists who've put their hands up to help in the special interest groups that Miranda's already mentioned. We've had more than 18 months of round-the-clock work on this to make sure that radiology has a central and strong voice in the design of this program. So which patients are going to be eligible for the program? Well, it's a fairly simple way of establishing eligibility. The patient must be between 50 and 70 years of age at the commencement of the screening. They must have a history of cigarette smoking, but it does include other types of tobacco smoking, such as cigars or pipes. And there must be at least a 30-pack year history. Now, you'll be all pleased to know that it is not up to the radiologist or the radiologist's practice staff to establish the eligibility of the participant. That is up to the referrer. Now, the patient can still be smoking, or if they are an ex-smoker, they must have quit within the last 10 years. And the reason for that is the longer the time period goes since stopping smoking, the closer to the baseline population of non-smokers the risk of lung cancer will be. And so quit in the last 10 years or currently still smoking. Now, the next one's really important. You have to be asymptomatic, because screening by definition is screening for people who don't have symptoms that would otherwise be investigated with regular diagnostic investigation. And so we should be getting patients who are asymptomatic. And every 2 years, the patient is able to come back and have another scan. But of course, if we flag something up in any of those scans, they may go through a different pathway with sooner follow-up imaging or be referred to a specialist for review in the respiratory physician team. But this is the eligibility criteria that the GPs and any other referrers will be using to determine whether a patient can come to for screening. Now, what does that actually look like for us? And over the coming webinars, we're going to have more information about the sorts of information that we need to put into our reports, because as we've already alluded to, there are different ways of assessing malignant potential of nodules when we're looking at a screening population compared to a diagnostic population. But radiology is going to be really core to this entire process. We anticipate that the majority of the CTs that will be performed as part of this program will be performed in private radiology practice. We anticipate and hope that there will be a fairly slow ramp up of the numbers of patients that we anticipate coming through, partly because patients will be seeing their GPs to be assessed for eligibility, having the consultation around, do you want to participate in screening? And, then the patient makes a booking and comes for some scans. It is going to take time for this to be accepted in the wider community, which is for us probably a good thing, because we anticipate that there will be a lot of CT scans coming our way. Now, we don't anticipate that these will all come through the door on day one, but we do anticipate that if the program is successful, that we will see a lot of extra CT chest studies coming through the radiology sector every year. So what does this mean for us as a workforce? Well, I guess the good news is that the majority of radiologists do at least some part-time in private practice. The bad news is that only 5% of radiologists have any subspecialty training in chest, and even amongst chest radiologists, there is limited experience in lung cancer screening within Australia because we haven't had a program here before. Now, the vast majority of radiologists perform at least some general work, which would include CT chest reporting. So we're not starting at a baseline of no knowledge about how to report lung nodules, but we are looking at a pretty significant effort to upskill radiologists in Australia to be able to address the requirements of the reporting for screening of lung nodules. And that's why attending these webinars, and as I'll go through in a moment, the other resources that will be made available will be really important prior to starting this work. Now, what are the key issues with trying to implement a training program about this kind of new skill? Well, it's a new skill, and that's the first thing. Not many of us have done this before. I didn't anticipate when I was in Canada in 2011 and PanCan was being done that I'd ever need to know about it for Australia, but here we are, and here we go. PanCan and the LungRad systems, which Miranda has already briefly touched upon, have not been widely used in Australia before, and so they're not well understood by general radiologists as a whole. On top of that, we have made a bespoke nodule management system for this program here in Australia, which brings together, we feel, the best of all of the available systems used elsewhere throughout the world, and it makes, we anticipate, the best use of our resources here in Australia. Now, you can rest assured that the radiologists have had a very strong and central voice in developing that nodule management system, including Miranda and the other members of the steering committee that I will mention in a couple of slides' time. In addition, we are now focusing on different characteristics about the lung nodules themselves. It's not just linear measurements and eyeballing, it's looking at the size and the volume and looking at volume doubling times and those sorts of metrics that we haven't routinely done before in the non-screening setting. And so across our sector, we anticipate that there will be an increased need for software tools to help us do this, to be more accurate, but also to make the time commitment easier for us as well. And so there will be, further information coming in several weeks around how to approach the issue of AI and CAD tools to help us do this across our sector. We also anticipate that there will be a sector-wide change in, not just our IT systems and our IT staff, but also the user knowledge across radiology about how to use these tools. We anticipate that there will be some integration challenges ahead, but we are working through those as well to make sure that the information that we derive from our reports can be absorbed back into the program register. So there will be a slightly new workflow for radiologists, particularly as the report template that we use to do our report is mandatory. We are all accustomed to being able to decide how we write our reports, but in this instance, because it's a screening program and the data will be collected and used for quality assurance as well as to generate recommendations for patients, we will have a report template which must be used by all the radiologists participating. And as I've said, this report will go up to the National Cancer Screening Register. So with all of this background in mind, what are we going to do about training all of us to do this? Well, the first recommendation is that if you're a radiologist who will be doing some of these reports, we do recommend that you undergo the training provided through the college. It's accurate. So very high quality examples. It's all evidence-based. They've all been ground truthed and vetted, by people like myself and Miranda, who have been involved in the program from the very beginning of the design. It's very accessible, it's free to all of the college members, and we provide multiple modalities of learning. So if you're somebody who prefers to watch a video, there'll be videos. If you prefer to read through something at your own pace, that's also an option. And there'll be lots of examples that you can work through in your own time in a PACS-like environment. So we've given this a great deal of thought and engaged with some excellent third-party partners to help with the radiologist education. Now, this is targeted to this program. All right, it's not just talking about PanCan or LungRads or something else entirely. This content has been curated for this program and what we need as radiologists in it. So it's not designed for GPs, it's not designed for respiratory physicians or surgeons, it's designed for us. And we think it's pretty comprehensive. So once you've had a chance to go through all of that information, you should be okay to start. It doesn't mean that you're going to be an expert at the very beginning, but you can always go back and look at the information again. So how are we actually going to do this? Well, as I said, we have this dedicated learning platform which has been customized and developed specifically for this learning example, and it is designed to replicate a PACS when you look through the images. As well as that, there's the learning management side, which is providing lectures and videos. The radiologists who are contributing content are experts in this field, and there's a range of means to absorb the information. CPD certificates will be included on the platform, very importantly, so that you can have evidence that you've actually done the work. It's all going to be online in terms of the online platform, and it will be web-based, so accessible from every one of your devices. If you're sitting somewhere waiting for something, you can pull it out on your phone or your iPad and start having a look. The videos, from what I've seen so far, are excellent, as well as the case gallery with feedback and annotations to show you, where you may have gotten things right or where you got things wrong. Webinars, well, we're all in one now, so obviously we've made it to the webinar invitation page, as well as self-assessment that you're able to do on the online platform, and then in-person workshops. So you will have all received an email or two from the college in the last couple of weeks with a list of the dates and venues for in-person workshops. It is, as soon as you get the email, if you're able to attend, please do, because once they fill, there's a limit to how many of these in-person workshops we can do. So please do register for them. What's it looking like at the moment? Well, we have an excellent subcommittee through the RANSCA-ANSTA, which is a great acronym, I think, working group specifically dedicated to the radiologist training and education package. We have a detailed work plan, all the contracts are in place to make sure that the platforms are available, and we've had excellent collaboration not only within our college but also with other stakeholders like the Thoracic Society of Australia and New Zealand and with Cancer Australia. As I've said, the dates for the workshops have been announced and the sign up is open, so please do join. We do anticipate that the online platform will be available in 2 to 3 months' time, to allow people to do some, dedicated training in the several months in the lead up to the program, which starts in July of this year. Now, I can't finish without acknowledging that there have been a lot of people working very hard on this program. And I'd like to first of all acknowledge everybody on the National Lung Cancer Screening Program Steering Committee from the ANZ Society of Thoracic Radiologists, and in particular to Miranda Simjanovic, who has been our leader and has worked incredibly hard, not just to generate an amazing amount of content, but also to keep all the balls up in the air. So Miranda, thank you very much. The ANSTA Training and Education Committee, I thank them for all of their time and effort on this as well. The college staff have been exceptional in this entire last 2 years, and before that as well, with advocating for a strong radiologist voice in the development of any new screening program that involves radiology. And I'd like to specifically thank Shelley Hansen, who has been at the helm of this for the college since the very beginning. Thank you, Shelley. And also to Liam and Graham for all of the work that you have done as things have intensified. Our clinical radiology dean, Dr. Rajiv Ratan, who has been exceptionally supportive all the way through the last 18 months. And to our collaborators from Cancer Australia, Professor Dorothy Keefe, but also Cindy Toms, who has been our main point of contact and our support. To the Department of Health and Aged Care, who have first of all developed the program, but have also been managing many, many moving parts, and in particular, Ms. Jessica Pratt, the Assistant Secretary, and our teammates at DetectedX, Professor Patrick Brennan and co, who have been extremely flexible in working with us to design the educational platform. So if you'd like to know more about it, we'll have certainly plenty of time now for some questions. And if you'd like to join ANSTA and not already a member, please do use this QR code, because this will allow you to join. I'd like to say it's free, which it is. It's fun. Mostly it is. It'll be more fun after July. And you'll get some newsletter updates to keep you informed about what's happening in the world of chest radiology, particularly important in the lead up to the start of the program in July. So that's all I had to say tonight. Maybe I'll throw it back to you, Shelley, and open it up to any questions from the group.
Thank you, Catherine. But do we have any questions? Hello, Tom. How are you?
Good. Hello, everybody. Catherine and Miranda, what do you think about the rebate, the price that's being paid for this? Do you think it's going to cover the costs, or there are too many unknowns?
Well, certainly from the point of view of a clinical quality, I'm sure that we as an industry group are certainly able to do it. In terms of being able to do it from a financial feasibility perspective, we're still having multiple conversations with government about what the appropriate rebate will be, and watch this space over the next month or so. It will be challenging to provide a huge number of extra CT scans without some acknowledgement of the additional time that people will take to train, but also some of the additional technical changes that we'll need to make across the sector. So watch this space.
What do you think is going to be the uptake amongst radiologists? I see that you have a very impressive turnout today of 150 or so of us, but that's still only about 10% of the radiologist workforce. Do you think that's going to be the final take up, or will there be more of us?
I think there'll be many more people who are interested in participating. It will depend a lot as well on people's existing commitments and how much of the work is coming through the door of their own practice. I know that many radiologists consider themselves to be generalists, but may have a subspecialty interest as well. So we are going to see wait with bated breath to see how many people attend our workshops. I certainly had excellent take up of the workshops when we run them as a trial last year. So we're anticipating that there'll be a lot of interest. As Miranda said earlier, this is the biggest project that we've ever had in terms of people volunteering to contribute their time over the last 18 months. So I think that's a measure of how interested we are as a craft group.
And we can also think of this sort of upskilling process as a staged process, in that we have a group of established working consultants who are learning a new skill, but at the same time, the intention is to incorporate lung cancer screening into the training curriculum. And as trainees progress through their training and come out the other side of their training already skilled in lung cancer screening, that's going to be a whole different wave of participation in the workforce. Question from Bev.
Is my mic working? Can you hear me, Miranda?
Yes.
Fantastic. Firstly, a massive thank you to yourself, Miranda, and you, Catherine, and all in the steering group and everyone that you've listed, Catherine, in the college and beyond. I, from here, can appreciate only a part of how massive this work has been. So thank you. The question I have is about AI, and I know you're all planning to discuss that in a later workshop, but I think the question is, for me, how you plan to train us with AI, what the recommendations are, how do we homogenize a process across the AI platforms? Even though many departments may have AI, they may not have used it for lung nodule detection in this manner or at all. So that's my first question. The second question is about the mobile vans, which I know, Catherine, I think it's your oversight, and who owns it in terms of reading it? Like, is it, you've mentioned before that a lot of these screening tests will be read and done in private. With these mobile vans, I assume they're going to be targeting certain demographic of patients who are a little bit more vulnerable, and how is that particular demographic going to be petitioned amongst all the participating institutions?
Go ahead, Catherine.
So two really good questions. I'll start with the AI one. So the good news for us is that all of the AI vendors are very excited about this program because, you know, this is potentially hundreds of thousands of scans per year. And so all of the vendors are working very hard to produce outputs which match what we need in our final reporting. They already, almost all of them, involve both a PanCan calculation as well as a lung-RADS categorization. So there's a small amount of editing that they will be needing to do that and to convert that into the nodule management classification we're using here in Australia. In terms of how we go about producing this, we will hear more about this in the webinar in a couple of weeks' time, but there's also some information that's coming out in the next couple of months from the college about the principles of choosing an AI tool for the purposes of lung cancer screening. There's also a ton of great articles already freely available in the medical literature, and our own college has put together a number of excellent position papers around the safe and ethical use of AI in diagnostic radiology. In terms of the second question about the mobile vans, the mobile van is run by a company called Heart of Australia. There will be 5 of them across the country. It's a start to being able to provide services to regional and remote Australia. It is certainly not going to encompass all of those areas. Australia is just too big a country with too many regional and remote areas to cover with 5 vans. Having said that, it is an important part of the program and is being funded centrally through the Department of Health and Aged Care in collaboration with NACCHO, overseeing the Indigenous community health organisations. The reporting will be done by chest radiologists, yet to be sort of determined exactly how many that will be. But if anyone is interested in participating in reporting of the studies and doesn't have access to it in their own institution, there will be many opportunities to contribute to it through other organisations. Yet to be worked out how we do that exactly from a logistical point of view. But yeah, we are anticipating that there will be no degradation in the quality of the image acquisition or anything else. Sorry, it's bedtime here at my house. Or if there's any pathology, that they will all be subjected to the same rigorous quality of reporting. And the QA of the program is including all of the mobile CT scanners, as well as, you know, any of the fixed scanners available around the existing CT infrastructure.
So, Catherine, are you saying that with the mobile vans, there's a separate group of radiologists, there could be a mix of various peoples from different institutions who are going to concentrate on the mobile scans?
No.
Or is that no?
No. What I'm saying is that everyone who goes through the mobile scanner gets exactly the same level of care and integration as they would as if they went to a private clinic that was a bricks and mortar clinic.
Yeah. Okay. The only reason I'm asking is I'm trying to run parallels between that and breast screen, where they also have mobile vans, and understanding the radiologist's role in particular mobile vans for breast anyway, and seeing if there's any parallels there. And with AI, is it compulsory that anyone who is participating in the reporting on acquisition of images that we are to report with AI, or is it highly recommended?
So it's not mandatory. However, it's in order to be able to deliver some of the information, particularly around volumes and volume doubling time, some form of software would be required to do that. Bear in mind that AI is just one version of computer-assisted detection, so CAD devices. You don't have to use AI, you can use a CAD device as well. So there are many different options out there, and as I've said, we'll get some advice out in the next couple of months.
Thanks so much.
So just to pick up on Catherine's last point there, we know that volumetry assessment is the most sensitive way to detect growth in nodules. So it is the recommended method of measuring nodules for the program, but you are able to enact the nodule management protocol without it. Tom's still got his hand up, but I think we've heard from you, Tom. if that's right, we might go to Warwick Lee.
Thanks, Miranda. Thanks, Miranda, Catherine, Shelley, and everyone involved. It looks like a fantastic program. This is a very simple question. I tried to register for the workshop at the annual scientific meeting and was not able to. I inquired from the college, and that won't be opening until April, when the ASM is announced. Is there any chance that this group can do an early registration for the annual scientific meeting?
Shelley, I don't know if you can
Workshop.
speak to that.
We will take that away, Dr. Lee, and see if we can work on it with our events team.
Thank you.
Question from Anthony Falburn.
Hi, thanks to everyone for the amazing amount of work that's been done so far. 2 questions. Are these patients going to just drift into my private practice, or they're going to be batched by someone else, or is it up to my practice to work out how we deal with these people? Number 2, if I have the a screening CT chest, and then my next patient is someone who fell off their motorbike and have normal CT chest, am I going, and I know they're smoking history, I'm going to change over to using PanCan and modified lung rads for my whole practice now, or is it just going to be used for screening and then use Fleischner for everything else? Or it's just, be running so many systems to try and work this out.
Yeah, good question. So to answer the second question first, what to do with incidental pulmonary nodule detection, that would be to continue reporting as per your routine reporting protocols, and most people are using Fleischner. The rationale behind that is that the framework in the nodule management protocol is all around the assumption that the participant is going to continue getting screening at certain intervals. So the management protocol decision making is all around that, and all around knowing the exact risk profile, because high risk is a spectrum. The participants that have been isolated for management through the program are of a particular high risk category, whereas a smoking history is only one part of a total risk profile assessment for a participant that also includes family history and various other factors. So the different screening intervals that are recommended in the different frameworks are sensitive to the fact that we've got a heterogeneous risk profile, and therefore most appropriately applied to specifically tailored settings. So the nodule management protocol will be for screening studies in the NLCSP, and incidentally detected nodules continue to be reported as per the guidelines that you're familiar with using. The question as to where these participants are going to be coming from, and are they just going to be walking in off the street, the intention is to encourage a two-way conversation between referrers, so predominantly GPs, and radiology practices, in that GP practices will be encouraged to reach out to their usual radiology providers and to check in with them whether they are screening ready and whether they are happy to receive these requests from day one. And radiology providers are encouraged to reach out to their usual GP partners to let them know, we're ready to go, please send them here, we're waiting.
Thank you.
If there are no further questions, that concludes our first webinar. We look forward to seeing you at the next one, webinar 2, and we will take that question away about early registration for the ASM in October, the workshops. So thank you very much, everybody, and look forward to seeing you again.
Thanks everyone for joining us.